Well, the general psychiatrists who really don't have child experience will look at these teenagers and often treat them as young individuals, which makes total sense if you're, a psychiatrist functioning kind of traditionally. But these kids are still highly dependent upon their families. Their families are still kind of facilitating avoidance behaviors, if you will, and accommodating to this kind of anxious stuff. There is a need for a kind of another conceptualization of these young adults. Even though they're over 18 and they can consent to treatment on their own and they can have their own confidentiality, they're still deeply embedded within the family context, and it's important to understand how important the family is to recovery. Part of the problem with undertreatment and underappreciation of anxiety disorders is that the diagnostic criteria are fairly straightforward and clear, but children with anxiety disorders have a way of living that is probably more characteristic and makes it easier to identify. So the big three non-OCD anxiety disorders are separation anxiety. These are kids who have predominant fear or worry about being separated from a caretaker. And so it makes it difficult for them to go to school. It makes it difficult for them to go to sleep at night. These are kids who won't do sleepovers. They will follow their parents around the house. They'll be quite clingy. They really don't like to be alone. There's kids, another group of kids who have more generalized worry. These are the worry warts of childhood. These are kids who ask a lot of questions, seek a lot of reassurance. They worry about the future. They worry about the past. They worry about death and dying. They live with a sense of dread about the future, if you will, because everything that's coming is likely to be not very happy for them or uncomfortable for them. And then the third group are those with social anxiety disorder. These are kids who are primarily worried about being embarrassed or humiliated in interaction. And so these are young people who often speak softly. They won't raise their hand in the classroom. They don't like to go to the board to show their work. They don't like to read aloud. They won't order their own food in a restaurant. They're quite shy in groups. And while if you're 6, 7, 8, 9, 10 and you're a little shy, not so bad. But if you're 15, 16, and 17 and you have social anxiety disorder, you are essentially crippled in one of the most important domains, and that's socialization for an adolescent. So the real impairment for these kids with social anxiety begins to present itself in mid to later adolescence when the social demand is high. The treatment for those, the evidence base is very well established. It includes the antidepressant medicines, the serotonin reuptake inhibitors, and there's now one medicine that's approved for generalized anxiety, and that's duloxetine for kids 7 to 17. And so we have very good data supporting the use of those medicines for anxiety disorders. Although benzodiazepines are commonly used in this population, the evidence base supporting their use just isn't there. And so also these are medicines that kids will develop tolerance to over time. So the real treatment of choice for the anxiety disorders is to focus on the antidepressants, either duloxetine or the SSRIs. For those kids who have partial or incomplete response, probably the most important thing is to make sure that the dosing is adequate. In our large-scale randomized controlled trial, we used sertraline, and the average age of the child in that study was 10 to 11 years old. And the endpoint dose, the target dose at the end of the study for responders was about 120 milligrams. So if you look at what the community standard is for the use of sertraline, it's probably 25 to 37.5. And so people who are chronically underdosing kids with anxiety are not likely to get the kind of benefit that we saw in the randomized controlled trials. Kids tolerate these medicines extremely well. And so they can take doses of 75 to 100 to 125 milligrams, and that offers them the best opportunity to have a full and complete response to their anxiety symptoms. I think in the community, start low, go slow is the watchword. The problem with that strategy is you, one, stigmatize kids by giving them a medicine, and two, they're still stigmatized by the condition because they haven't had complete recovery. So what we're trying to do in our treatment strategy is to get kids well so that they and the medicine, they understand the relationship and the role of the medicine in their recovery. Their adherence is better. They have a chance to really build natural coping and adaptation skills because they're living a non-anxious life. Things really come around for the youngsters when they get good treatment, and we don't do them any favors by starting low, going too slow, or using inadequate dose. Getting to the right dose and getting anxious kids better is really the goal of treatment. Well, I think there's a couple of things in terms of next treatment steps. We know that medication management works very well for properly selected cases. We also know that CBT works very well for properly selected cases when it's done by a real expert in CBT. We know those treatments work well, but not everyone responds. So trying to identify, first of all, who gets better with what treatment, what's the kind of characteristic symptom pattern, age, sex, duration of illness, all those things I think are really important to understand. The other thing is long term. It's like, how long do you have to treat in order to kind of make sure that people not only recover but have some chance to come off medicine or to leave therapy and function without anxiety. We really don't know how long we have to treat in order to achieve that goal, so that would be an important thing. Our medicines are good, but they're not great, so it'd be very nice to do and understand whether there are other kinds of medicines that could be useful for the anxiety disorders, and so there's a variety of new compounds we're hearing a little bit about today at the APA that are in the experimental phases that come at anxiety through a different mechanism of action. So I think it's important for us to kind of stay up to date. That they're probably a long way from coming to the market, but it is important from a neuroscience point of view to understand what other medications, what other mechanisms might be effective in reducing anxiety.